Imagine having an ulcer on your tongue that hurts so much, the pain actually registers deep inside your ear.
Yeah, it's a brutal kind of referred pain.
Right. Every single time you swallow, there's this sharp, stabbing sensation shooting right up into your auditory canal. And that crosswire in the nervous system, that's exactly what a 55-year-old patient from Malad was experiencing when she walked into an oncology clinic.
And she wasn't just dealing with a minor sore either.
No, not at all. She was presenting with a 3.5 by 2.5 centimeter ulcer on the left side of her tongue, and she had been living with this open lesion for 6 months.
6 months is a long time for a lesion like that.
It really is. So today we have a unique mission for you. We are going to decode the actual high-level medical transcript of her case presentation. This is straight from a tumor board at Tata Memorial Hospital.
It's a fascinating look behind the curtain.
Exactly. We are stepping out of the, television medical dramas and into the real, intensely strategic, basically chess-like world of surgical oncology.
I mean, the transcript we're looking at today, it's essentially a crucible. You have the senior oncologist grilling a resident, really pressure testing every single clinical assumption they make.
They aren't just logging symptoms down on a clipboard.
No, they're building a predictive model of how this specific tumor behaves. And when you read the presentation, the very first variable they isolate isn't even the ulcer itself, it's her history.
Okay, let's unpack this history, because they specifically note a 10-year habit of chewing pan masala.
Right, and even though she quit 4 years prior to this presentation, that decade of exposure is the critical factor.
Because of the ingredients in it.
Exactly. The areca nut and the slaked lime of the pan masala. They essentially bathe the squamous cells of her oral cavity in reactive oxygen species.
Oh, wow.
Yeah, so those genetic mutations, they accumulated silently over a decade. It takes years for that damage to finally manifest as a malignant ulcer.
That makes a lot of sense. So looking at her specific physical presentation, the resident notes she has severe dysphagia, so trouble swallowing, plus speech changes that have worsened over 2 months, and of course that radiating ear pain.
Right, the classic signs of an advanced local tumor.
When they physically examine the mouth, they describe the ulcer's induration as extending all the way to the midline of the tongue.
Induration being that rock-hard texture of the tissue surrounding the visible sore.
Yeah, and initially I kind of thought of this like an iceberg, right? You have a small visible tip on the surface, but there's a massive block of ice hidden underneath.
That's a common way to think about it, but structurally it's actually much more aggressive than just a static block of ice.
Really? What's a better analogy then?
Well, a better way to visualize induration is to think of invasive tree roots. The tumor isn't just sitting there taking up space. It's actively sending microscopic tendrils deep into the muscle fibers of the tongue.
Oh, that sounds awful.
It is. And the body's immune system tries to wall it off, which creates this dense fibrous stromal reaction.
So it's fighting back, but that causes scarring.
Precisely. That combination of tumor infiltration and the fibrous scarring, that is what the surgeon feels as a hard, woody texture when they examine it.
And I guess those roots explain the physical symptoms perfectly, right?
They do. The tongue is basically a densely packed bundle of intrinsic and extrinsic muscles. So if those muscles are tethered down by the tumor and the scar tissue, her dysphagia is inevitable.
She physically can't lift her tongue.
Right. She cannot elevate the base of her tongue to propel a bolus of food backward.
Wow. And what about the ear pain? How does a tongue ulcer make your ear hurt?
That really just comes down to the neuroanatomy of the jaw. So the anterior 2/3 of the tongue is supplied by the lingual nerve.
Okay.
And that nerve is a branch of the trigeminal nerve. Well, the trigeminal nerve also supplies sensory branches to the ear, specifically the auriculotemporal nerve.
I see where this is going.
Yeah, so as the tumor's roots infiltrate and irritate that lingual nerve deep inside the tongue, the central nervous system basically misinterprets where the signal is coming from.
It's getting its wires crossed.
Exactly. The brain maps the pain directly to the ear,
That is wild. Okay, so based on that clinical exam, the resident stages her at T3, N1, M0.
which is a crucial classification.
Right, and just to briefly translate the universal language of oncology for you, T relates to the primary tumor size and depth, N is the lymph node involvement, and M is distant metastasis.
Right, so in this case,
So they have a T3 primary tumor, a single 1.5 centimeter clinically positive lymph node in the neck for the N1, and M0 means zero spread to distant organs like the lungs.
spot on. And that T3 designation here is the critical part. It implies a really significant local advancement.
But the physical exam alone isn't enough, right? Even with an experienced surgeon feeling that whole indurated root system.
No, it only gives you a rough approximation. You absolutely cannot plan a complex surgical resection based solely on what your finger can reach.
Which brings us to the imaging phase of the transcript. They detail a really heavy reliance on a preoperative MRI.
The gold standard for this area.
But I actually have to challenge the clinical logic here for a second. I mean, I'm looking at a patient who is in severe pain, she's struggling to swallow, and she has an aggressive cancer.
Right, time is of the essence.
Exactly. A standard CT scan takes, about 60 seconds? And it's infinitely cheaper. Meanwhile, an MRI requires her to lie perfectly still in this claustrophobic tube for 45 minutes.
It's definitely a rough experience for a patient in pain.
So why subject her to the delay and the discomfort of an MRI? Why not just get a quick CT scan and rush her into the operating room?
It's a fair question, but a CT scan mostly maps physical density. It is brilliant if you're trying to visualize the rigid cortex of the jawbone or, say, the air-filled spaces of the lungs.
But the tongue isn't bone.
Exactly. The tongue is a completely homogeneous mass of soft tissue. It's just muscle, fat, and minor salivary glands. On a CT scan, a soft tissue tumor often just blends right into the healthy muscle. You can't see the edges.
Oh, I see. And an MRI does that better.
Much better. An MRI maps the behavior of protons in water. Because tumors have different cellular densities and water content compared to healthy muscle, the MRI gives you this high-definition contrasting map.
So it shows them exactly where the tumor ends and the healthy muscle begins.
Right, and the surgeons specifically drill down on using that MRI to determine the depth of invasion, or the DOI.
They mentioned DOI a lot in the transcript. Why is that specific metric so important?
Depth of invasion is really the ultimate prognostic metric in oral cancer. It is not just about how thick the tumor is on the surface.
It's about how far down it goes.
Yes, it's a measurement of how deeply the malignant cells have breached the basement membrane of the tissue. If an MRI confirms a DOI greater than 10 millimeters, the staging automatically escalates to T3.
Just based on that depth alone.
Yep, because at that depth, the tumor has direct access to a rich network of blood vessels and lymphatic channels. It can spread much easier.
Got it. And the MRI also answers some structural questions for them, right?
It does. It shows if the tumor is wrapping around the major neurovascular bundles, and whether it has infiltrated the extrinsic muscles like the genioglossus, that actually anchor the tongue to the jawbone.
Because if it anchors to the jawbone, this whole surgical chess match changes entirely.
Completely changes the game plan.
So once they have that MRI blueprint, they have to physically remove the mass. And the parameters they discuss in this transcript for the removal, they are just brutal.
The margins are definitely aggressive.
The surgeons aim for a 1 to 1.5 centimeter mucosal margin. Now, in a lot of medical literature, taking margins is compared to cutting a bad spot out of an apple. You take a little extra crisp, healthy apple just to be totally safe.
That's a good basic way to understand it.
But in the oral cavity, we are talking about cubic volume. Extracting a 4 centimeter mass with an additional 1.5 centimeter perimeter of perfectly healthy muscle in all 3 dimensions, that is a devastating loss of real estate.
It really is. You are sacrificing crucial anatomy to guarantee you leave zero microscopic disease behind. The mouth is an incredibly compact, highly functional space.
So losing that much muscle has to impact her heavily.
Massively. Losing that much intrinsic muscle means losing the fine motor control required to articulate words or just maneuver food around your mouth. But the biological imperative has to override the functional cost.
You have to get the cancer out first.
Right. And furthermore, tissue actually shrinks once it is excised and sent to pathology.
Wait, really? It physically gets smaller?
Yes.
Oh.
A surgeon might cut a 1.5 centimeter margin in the operating room, but by the time the pathologist measures it, it might only be 8 millimeters. You have to overcompensate.
Wow, that makes the logistics of getting those margins even harder, which brings up a massive clinical hurdle they face in the transcript. You have this large tumor at the back of the oral cavity. To extract it safely, you need visibility and physical access.
The access debate is one of the most tense parts of the presentation.
Yeah, they debate two approaches. There's the peroral approach, which means working entirely through the open mouth, versus a mandibulotomy.
And a mandibulotomy is extreme. It requires an incision right through the lower lip and then completely splitting the mandible bone with a saw.
They literally saw the jaw in half.
Yes, they swing the two halves of the jaw outward to expose the base of the tongue. It adds tremendous morbidity. It requires titanium plates to reconstruct the jaw later, and it severely complicates the patient's recovery.
Obviously, the surgical team wants to avoid sawing her jaw in half if they can. They want to stick to the peroral approach, but they hit a wall in the transcript.
The trismus.
Right, the resident notes the patient has trismus. Her jaw is physically locked, heavily restricting her mouth opening. You can't perform a peroral resection if the mouth literally won't open.
It's a huge mechanical problem.
So how do they proceed? Do they just assume the worst, prep the bone saw, and go for the mandibulotomy?
Actually, no. They rely on a really clever, real-time diagnostic test right on the operating table using anesthesia.
How does that work?
Well, trismus can be caused by two very different mechanisms. First, the tumor might have physically grown into the medial pterygoid muscles. Those are the primary muscles of mastication or chewing.
Okay, so if the tumor is in there, the jaw is physically tethered shut.
Exactly. But the second cause is purely physiological. The patient is in so much constant pain that the jaw muscles are in a state of severe involuntary spasm.
So by inducing general anesthesia and giving her a paralytic agent, they completely remove the pain and the neuromuscular spasticity.
Precisely. Once the patient is under general anesthesia, the surgeon manually tests the jaw. If the mouth suddenly opens wide, they know the trismus was just pain-induced.
So then the peroral approach is viable and they spare the jawbone.
Yes. But if the jaw remains rigidly locked, even under anesthesia, the trismus is mechanical. The tumor has definitely infiltrated the pterygoid muscles, and the mandibulotomy is completely unavoidable.
That is an incredibly elegant pivot. So let's assume the trismus releases, they proceed perorally, and they successfully resect the primary tumor with those wide margins.
The primary site is clear.
Right, but the operation doesn't end there. The surgical team immediately shifts their focus to a prophylactic strike on the neck. They detail an ipsilateral neck dissection, meaning they're clearing out lymph node levels 1 through 4 on the same side as the tumor.
Right, because the neck is divided into anatomical levels for surgeons. Level 1 is right up under the jawline, stretching all the way down to level 4, which is near the collarbone.
But the clinical exam and the MRI only flagged a single 1.5 centimeter lymph node at level 1. Levels 2, 3, and 4 appeared completely clinically negative.
They looked clean on the scans.
Yeah. I can understand taking the local nodes right next to the tumor, but why strip the entire lateral side of her neck down to the collarbone if there is no visible disease there? Here's where it gets really interesting.
This gets to the phenomenon of skip metastasis.
Oh.
It's a hallmark of these aggressive oral cancers.
Because normally we visualize the lymphatic system as the sequential highway system, right? Where cancer cells enter at an on-ramp and systematically stop at the very next exit.
That's how it works for many cancers, yes. But the lymphatic drainage of the oral tongue is incredibly complex. It acts a lot more like an unpredictable river delta.
It's like an express train bypassing all the local stops.
Exactly that. The lymphatic channels from the tongue can anatomically bypass the submandibular nodes at level 1 or the upper jugular nodes at level 2 and just drain directly into the mid or lower jugular nodes at levels 3 and 4.
Wow. And the transcript highlights that in these specific cancers, there is a 15.8 to 20% probability of skip metastasis.
Think about that. You have a roughly 1 in 5 chance that microscopic cancer cells have ridden that express train straight down to the lower neck.
You just cannot risk leaving a microscopic time bomb behind simply because the scan looked clean.
You'll be setting the patient up for a massive recurrence.
Now, the board also interrogates the resident on when they would perform a contralateral neck dissection, meaning clearing out the opposite side of the neck too.
Right, going after both sides.
And they conclude they would only cross over if the primary tongue tumor physically crossed the midline of the mouth, or if the ipsilateral neck was so overwhelmingly packed with metastatic nodes that the lymphatic flow actually reversed and pushed back across the neck.
Which highlights a really deliberate restraint on their part. A bilateral neck dissection severely impacts venous drainage from the head.
It causes lots of swelling.
Massive facial edema, and even an increased risk of intracranial pressure. They only deploy it when the anatomical evidence absolutely demands it.
That makes sense. There is also a brief mention of a sentinel lymph node biopsy in the text. That's a highly targeted technique where you inject a radioactive tracer, locate the exact first node that the tumor drains to, and only remove that specific node.
A much later surgery.
Right, so why isn't that an option here to save her from a massive level 1 through 4 dissection?
Well, sentinel node biopsies are highly effective for early, like T1 or T2 cancers. But in an advanced T3 case with a clinically palpable node already present, the architecture of the lymphatic system is compromised.
Because of the tumor bulk.
Yes. High volume disease can literally clog the primary lymphatic channels. That forces the radioactive tracer to redirect to alternate secondary nodes instead.
Oh, so you end up with a false negative. You're tracking the wrong path and leaving the real metastatic nodes behind.
Exactly. The disease burden here dictates a comprehensive clearance.
Okay, so you've excised the primary tumor, you've stripped the lymphatic plumbing from the jaw down to the collarbone. Now, the surgeon is staring at a massive anatomical void in the patient's mouth.
The reconstruction phase.
Right. The transcript classifies this as a type 3 defect. If you simply pull the remaining edges of the tongue together and suture them closed, you essentially tether the tongue tightly to the floor of the mouth.
Which is a functional catastrophe for the patient.
Because they can't move it at all.
Right. If the tongue is anchored to the floor of the mouth, the patient loses the ability to articulate speech, and more importantly, loses the ability to initiate the swallowing reflex.
Which means they could choke.
Saliva and food will just pool in the oral cavity, or they'll aspirate it straight into the lungs.
So, to restore function, the surgeons have to completely reconstruct the tongue using tissue from a distant site on the patient's body.
They have to borrow from Peter to pay Paul.
They debate two primary options for a free tissue transfer, or a flap as they call it: the anterolateral thigh flap, taking tissue from the leg, and the radial forearm free flap, taking tissue from the arm.
And this is where surgical oncology merges with microvascular engineering. I mean, they're not performing a simple skin graft here.
A skin graft wouldn't survive, right?
Not at all. Skin graft would just die in that environment. They are harvesting a complete block of skin, fat, and fascia, along with its dedicated artery and vein.
The plumbing aspect of this is staggering to me. They harvest the tissue from the thigh, physically carry it over to the head and neck, and then, using a microscope, suture a 2 mm artery from the thigh tissue into a severed artery in the patient's neck.
The precision required for microvascular anastomosis is immense. The inner lining of those blood vessels, the intima, is highly reactive.
What happens if they bump it?
If the surgeon's needle traumatizes the intima during the suturing process, the body's clotting cascade activates. A microscopic thrombus forms, blocking that tiny 2 mm artery, and the entire constructed tongue basically dies of ischemia within hours.
That is incredibly high stakes.
It is.
And choosing between the thigh and the forearm really just comes down to the required volume. The thigh provides more bulk, which replaces that dense muscle mass lost during the T3 resection.
Right, it fills the void.
Whereas the forearm provides thinner, more pliable tissue, which is excellent for mobility, but might leave the reconstructed tongue lacking the volume needed to actually touch the roof of the mouth during a swallow.
It's all about matching the defect. And, even after surviving the resection, the neck dissection, and that whole microvascular reconstruction, the patient's journey isn't over.
Not by a long shot. The transcript concludes by outlining the adjuvant or postoperative treatment plan. The tissue removed in the operating room is analyzed by a pathologist.
The surgeon is relying entirely on that pathology report to dictate the final phase of the strategy.
And the board specifies a few critical red flags. For instance, if the pathologist finds positive margins, meaning cancer cells extend all the way to the outer edge of the removed tissue, or if they find extranodal extension, the game changes.
Extranodal extension, or ENE, is a major one.
That means the cancer didn't just travel to the lymph node, it physically burst through the capsule of the node and began invading the surrounding soft tissues of the neck, right?
Yes. ENE fundamentally alters the prognosis. It indicates a highly aggressive tumor biology. The physical barrier of the lymphatic system has completely failed.
And another major red flag I look for is perineural invasion.
Where the cancer cells exhibit a specific affinity for nerve tissue. They track along the nerve sheaths like wires through a wall, spreading far beyond the primary tumor site.
So if the pathologist identifies ENE, positive margins, or perineural invasion, the surgical intervention is deemed insufficient on its own.
Surgery alone won't cure them at that point.
The patient is automatically slated for aggressive radiation therapy, often combined with chemotherapy, to basically sterilize the surgical bed and eradicate whatever microscopic disease was left behind.
This perfectly illustrates the multidisciplinary reality of modern oncology. The surgeon physically debulks the disease and secures the anatomy. But the pathologist, the medical oncologist, and the radiation oncologist, they must all coordinate to secure the biology.
So what does this all mean? You look at a medical transcript like this, dense with staging criteria and surgical acronyms, and it initially reads like an impenetrable technical manual.
Practically a foreign language.
Exactly. But when you break down the mechanics, the logic of the margins, the neuromuscular test for trismus, the microvascular plumbing of the reconstruction, you realize it is an intensely predictive science.
Every move anticipates the tumor's next move.
Right. The clinical teams are constantly weighing the brutal mathematics of aggressive resection against the deeply human necessity of preserving a patient's ability to speak, to swallow, and to interact with the world.
It is a remarkable balance of destruction and reconstruction. And honestly, observing the sheer complexity of harvesting an anterolateral thigh flap to rebuild a tongue, it really makes you look toward the horizon of this field.
Where do you see it going?
Well, we are currently relying on autologous tissue borrowing from the leg to pay the mouth, which leaves the patient with significant donor site morbidity and a long recovery.
Right, they have to heal 2 major surgical sites now.
Exactly. But as we see rapid advancements in 3D bioprinting and tissue engineering, you have to wonder how long this current gold standard will hold.
You think we'll be printing tongues?
I think we are moving toward a future where a surgical team might simply map the type 3 defect with a spatial scan and then bioprint a custom scaffold seeded with the patient's own stem cells.
That would be incredible.
No secondary incisions, no harvested leg tissue, just a laboratory-grown, microvascularly intact tissue patch engineered specifically to replace the excised tongue.
Just skipping the donor site entirely and printing the required anatomy, that completely upends the limits of how wide a surgical margin could safely be, especially if reconstruction was no longer restricted by what you can harvest from the patient's own body.
It changes the entire math of the surgery.
It is definitely a fascinating space to watch. Thank you for joining us as we unpack this tumor board transcript. We hope it gave you a new lens on the highly strategic mechanics of surgical oncology. Keep questioning the data, keep exploring the mechanics behind the medicine, and we'll catch you on the next deep dive.